And then lastly, our last target of great interest in triple-negative breast cancer is AKT, which is so important since so many triple negatives have lost PTEN, INPP4B, and have activated AKT. So update us on what's going on there, Komal.
So a very small proportion, unlike the ER-positive population, which has about 40% of PIK3CA mutations seen, a very smaller proportion have alterations in the PI3K, AKT/mTOR pathway, yet present significant enough for us to think about targeting this pathway for this particular subtype. And the very first AKT-targeted trial was the phase 2 LOTUS trial that has now been published. And this trial looked at a specific AKT inhibitor, ipatasertib. And they looked at in patients in the first-line triple-negative metastatic setting where they combined it with paclitaxel. So patients either got paclitaxel with placebo or paclitaxel with ipatasertib. And the primary endpoint was to look at progression-free survival in the entire population, but they had a stratification factor specifically for patients who had a PTEN low status. And so in terms of the primary endpoint, there was a numerical increase and a statistically significant increase in the progression-free survival, but that was rather modest, the same way we see it in our ER-positive patients with PIK3CA mutations and PI3K inhibitors. But when they looked at the PTEN low status, this benefit was slightly larger and better. And furthermore, they looked at into a smaller population where they had any alteration in the PI3K, AKT, or PTEN loss, and there they saw that the benefit was even slightly better. So that's why I think the next step for this agent is in the phase 3 study, which is the IPATUNITY study, which is looking at this combination in the first-line setting in patients who have an alteration in the PI3K, AKT, mTOR, or have a PTEN alteration. So I think that result will really help us define space for this molecule in the triple-negative subtype.
And then there are other AKT inhibitors that are quite interesting, I think, that are coming down the pike. I think we'll see, I think, quite a lot. I was surprised by the LOTUS data, and I think even more interested in the suggestion of a survival benefit that Rebecca Dent presented. And then the Peter Schmidt's data on AZD5363 is intriguing as well. So kind of a new area opening up in triple-negative disease.
Yep. Well, thank you guys very much. I think we covered the waterfront here from ASCO, and just a chance to maybe we'll start with Komal and go down the table. Any last comments people want to make, or anything you want to emphasize from ASCO? Or
I think our themes of where to escalate and where to de-escalate are very obvious now in these meetings, where we're trying to add more targeted therapies to a backbone of agents. Our example is our CDK4/6 inhibitors or everolimus. We have newer targeted agents, and then we're also thinking about de-escalation and trying to figure out where we want to de-escalate so that we can avoid the financial toxicities and the physical toxicities of combination therapies. So I think we are making a lot of progress, and I think we're looking forward to more and more of this data so we can further refine how we treat our patients in clinic and give patients what they need, whether it's more or less.
Thank you.
Yeah, I agree. I couldn't agree more. I would just add that I think the biomarker era and the era of personalized medicine is coming now. We are actually seeing data like the data from LOTUS that is helping us to define patient populations where our therapies will work. And I think things like cell-free DNA and circulating tumor DNA is going to be a huge impact in the future in the way that we design studies to evaluate how to best treat patients using real-time data about what's happening with the tumor.
I think for me, the soft and text update, and simultaneous publication in New England Journal with this, huge benefit, absolute 10 to 15% absolute benefit in disease-free survival with an LHRH agonist and an AI, even over LHRH agonist and tamoxifen, never mind tamoxifen alone. It's practice changing as I look back over the years, at women who did not get that therapy in my own practice, and because of this differential between tamoxifen and AI, I think. And we've seen that in the postmenopausal setting too. It's that early split in the curve that makes a difference in AI versus tamoxifen. So the same is true there. And we just, that's very, very definitely practice changing. That's a big benefit for the younger woman going forward.
Well, I think we're continuing to make incremental changes in personalized therapy, basically. Maybe not huge steps this time, but even if you talk about things that are maybe a little bit lower tech, like ovarian suppression and the impact that that has, and then balancing it against side effects using PRO data that's been generated so that you can actually help decide who's going to go through those therapies and how to monitor them, all the way up to real-time molecular monitoring, for which I hope starts to get built into some of our studies, because then we can get a very early look as to whether someone's destined to progress or not. It may even give our patients opportunities on some of these novel phase 2 trials to get one of several therapies in sequence and then stick with the one that dropped their molecular counts the most. We're not quite there yet, but these are the kinds of things that where I think we're going to be moving toward.
Thank you. Hope, how about you?
Well, so that, I of course agree with what everybody has said, but I think one of the encouraging things to me about this year's ASCO in particular, and maybe this year, 2018, is that we're not seeing all these big non-focused trials, and hopefully what we're doing is changing the whole thinking into treating patients better and in a smarter way by understanding the genomics and changes of the cancer, by understanding benefit from various different therapies. I think Taylor X obviously is practice changing. I think the updated data from TEXT and SOFT is incredibly important for our patients. But I also feel like the studies looking at different pathways that are being targeted, that are suggesting early benefit and changes over treatment time. This is really, really exciting, and to me the most exciting area right now.
Well, thank you guys very, very much. Really great conversation and contribution. So thanks so much. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be very useful and informative.